Good afternoon and welcome to our May ICE webinar. Today we are joined by Jim Rickner, Director of Service and Training at Advanced Ultrasound Systems, and he will be discussing mastering the use of a tissue mimicking phantom for ultrasound. Now, with over 40 years of experience in electronic and medical equipment service, Jim brings deep field expertise to his role. A dynamic educator, Jim is a frequent presenter at national webinars, workshops, and industry events. He has also trained countless clinical engineering teams through on-site sessions at hospitals nationwide, empowering them to perform preventative maintenance, advanced troubleshooting, and in-house repairs. ICE Webinars would like to thank our sponsor, Advanced Ultrasound Systems. AUS delivers fast, affordable, and expert support for all ultrasound brands. The company has established itself as a trusted leader in comprehensive ultrasound care, dedicated to maximizing system uptime and performance for healthcare facilities nationwide. Their technical expertise encompasses every aspect of ultrasound technology, from complete systems and probes to intricate repairs at the combatant level. So for more information, please visit advancedultrasound.com. Okay, today's live webinar is eligible for one art category A, CE credit by the AHRA, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download your certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. I just wanted to give a quick mention to invite you to our ICE magazine for our annual Drinks on Ice at the ICE networking event at the AHRA 2026 on July 13th in Orlando, Florida. Some more details can be found in the handout section of your dashboard. We'll be wrapping up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Okay, let's kick off today's webinar by giving away one of our ICE gym bags to the attendee that can tell me the answer to the following trivia question. Today is Cinco de Mayo, so what fruit juice is used in a margarita? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenter today is Jim Rickner. So Jim, you may begin whenever you're ready.
Thank you, Linda, and welcome everyone. Today's one of my favorite presentations I give throughout my time. And it's important to me because using a phantom, I've been doing this for over 20 years now, working with them, and it's often misunderstood and misused. So back many years ago, I had a meeting with several engineers. One had 20 years in the field, and one was less than 6 months in the field. And I had them do phantom testing independent of each other and show their results and kind of demonstrate how they performed phantom testing. And two engineers working in the same company had completely different techniques. And that kind of illustrated a problem. And since then, I've kind of taken it upon myself to try to educate biomeds, clinical engineers, imaging engineers in the proper use of phantoms. And that's really what today's about. So thanks everyone for joining. Today we're going to talk about phantom imaging. We're going to understand the principles of image quality, what that means. Understand the relationship between frequency and resolution. We're going to try to become familiar with the different types of resolution. We're going to discuss those in detail. And then we're also going to talk about how you can use a phantom to evaluate image quality, something that you should have access to while working on ultrasound. And then lastly, we're going to talk about the different tests that are needed to confirm a quality image on an ultrasound system. So it's kind of a roadmap of where we're going today. So without any further ado, what is image quality? It's a really difficult thing. You go in to troubleshoot an ultrasound system, and the sonographer is saying, my image isn't right, and so you try to ask more questions like, well, what's wrong with your image? And the sonographer goes and says, well, my image is washed out, or it's grainy, or it's mushy. And it sounds kind of funny, but those are very technical terms, right? It really doesn't tell you anything about what's going on. The other famous one is, well, my image sucks. Well, how's that affect us? How does that help us solve your issue? That's kind of the problem is we need to be able to solve your issue, and with definitions like that, it becomes difficult. So one of the things that we try to do then is, start troubleshooting the actual issue they're describing. How has the image changed over time? Do they have an image from 2 weeks ago, let's say, that is clear and what they consider to be a good image, and can they compare it to an image they took today and try to demonstrate or show what the issue is, what it looks like. And sometimes they can do that, and sometimes they can't. Which makes, clearly if they can't go back to an old study and show us, hey, this is when it looked good, and compare it to a recent one, it makes it very difficult for us. The customer interview is integral, and I joke, I guess it's really not a joke. I don't call it a customer interview anymore. I call it a customer interrogation. Because for whatever reason, a lot of times they want to tell you something's wrong, but they don't want to give you all the information that they have. And a short story just to kind of illustrate this point is, I went into a customer. I had known him for a long time. He had an old Logic 9. This is many, many, many years ago. An old Logic 9. He had a color artifact, and I went in to troubleshoot on day one without parts because, he called me and I was local. So I went in there, and sure enough, it was a color artifact. It was happening on 2 probes hooked up to the system. There were 2 different types. They were a curved and a linear. Both had significant color artifacts in them. So, multiple probes, multiple ports, both having color artifacts. I started to work that day with no parts. I did what I could. I looked at settings, and I did a software reload, not really imagining that I would fix anything, but it's what I had available at the time. So I did a software reload, and sure enough, no change to the image quality. So I ordered parts for the second day, and came back and installed parts. And when I was done installing the parts, there was no change to the image quality. So again, I didn't get every part in the system, so I decided, well, maybe the back-end processor, the computer system, wasn't working. So I ordered another part, and came back on the third day, and that didn't fix the system. I got to day 4 and installed several other parts, basically rebuilding the entire system. And when I was all done, the color artifact still was present. And I was completely baffled. In fact, I was fairly upset. Now I've spent 4 days troubleshooting and working on the system. I've virtually rebuilt the whole thing, and nothing. So I went back and I got the sonographer, and I asked him to come in, and he came into the room, and there were parts everywhere. I'd installed probably 12 parts at this point. So there were parts everywhere. The system was up and running with the color artifact. And I said, I'm stuck. I said, I'm clearly missing something. So I think I'm going to have to start over. I said, but I just want to ask a few questions. I have these 2 probes, and I said, they're both producing color artifacts. Do you have any other probes? And he goes, yeah, there's one over here in the drawer, but it's not doing a color artifact. And I'm like, well, what do you mean it's not doing a color artifact? He goes, yeah, it's working fine. And that right there would have been information I would have loved to have had on day one. And if I had, I guess, interrogated him, I could have figured that out on day one. But my assumption was with multiple probes and multiple ports, it has to be something system related. So I went into the drawer, got the probe, plugged it in, no color artifact. The next day, I ordered 2 probes that day. The next day, I returned with 2 new probes and no color artifact. And so the customer interview, I guess, is what I'm trying to get at, is a very, very important part of understanding what's going on with your ultrasound system and trying to get to the bottom of image quality issues. Use the knowledge of the sonographer. They're the image experts. We're the engineers. We're the people that can go in and fix it once we understand what issues they're having and what, you know, the potential causes are. So, customer interview or interrogation. One of the things that is important and integral to know about probes, ultrasound transducers, is that frequency matters. And it seems kind of simplistic to say that, but when you realize that the higher frequency probes have better image resolution, better axial resolution, which we will define here during this presentation, they have better resolution, but they can't penetrate as deep. So high frequency probes, high resolution, low penetration. Where the low frequency probes have high penetration but low resolution. So everything in ultrasound, as far as probes go, is with a sacrifice. Either you're sacrificing penetration to get better resolution, or you're sacrificing resolution to get more penetration. And it's crucial for you to know that and to recognize that while you're troubleshooting image quality issues. Is it a problem, a real problem, or is it because they're using a different probe, perhaps a different frequency setting? It's important for you to understand the relationship that frequency has on image quality. So it's kind of a pillar of ultrasound. When we talk about image quality, there's several parameters we need to discuss and several definitions we want to use. So let's start with some of those, and just, we're not going to get into the details of them, but we're going to, talk about them. Detail and spatial resolution is the ability to distinguish small structures both axially and laterally, and we'll define it more. Image uniformity is comparable detail and contrast throughout the image. You don't want dark spots going horizontally or vertically through the image. You want it to be uniform from top to bottom, left to right. Contrast resolution, the ability to differentiate different tissue types without introducing noise. A different way of saying different tissue types is different densities. Okay, so every tissue type has its own specific density, and what we're doing with contrast resolution is ensuring that the system has the ability to distinguish the different tissue densities. Temporal resolution versus frame rate. It's the rate to acquire frames and display them. This is normally measured in hertz. For example, 30 hertz, or the image is refreshed 30 times a second. So temporal resolution / frame rate. Dynamic range, largest and smallest signals acquired and displayed. Okay, largest and smallest echoes. Spatial spatial discrimination, the ability to limit artifacts and reflections from other locations. Artifacts are kind of a way of doing business in ultrasound. You have to learn how to move the probe, move the patient, change the way you're looking at an object in order to limit some of the artifacts if they're not, you know, a problem with the probe or the system. Bandwidth is the system's ability to reproduce signals appropriately. We use the term bandwidth on probes an awful lot because we have what we consider multi-frequency probes now that have multiple frequencies with one probe. That's pretty standard in all ultrasound probes today. So to break it down further, let's talk about image resolution, and specifically we'll start with axial resolution. Axial resolution is a minimum separation between two structures the ultrasound beam can distinguish parallel to the beam path. And the two structures that we're trying to define here are these two blue dots in the image area, okay? These black curved lines that go down here just represent where we're focused with this particular probe. So clearly in this area here is where we have the best focus. And the question is, these two structures, can we see them independently, or do they blur together as one larger structure? If they appear as one object that is just kind of smeared together and one larger structure, then we would consider it to have poor axial resolution. So that's what we're doing. In this case, because the focus is so narrow, we would see these as two objects. But if we moved them up here, these two objects up into the near field, where the focus isn't near as narrow, then they would blur together as one larger object. Same thing if they were down in the far field. So it's important that we focus and tell the machine where we want to focus when we're trying to evaluate axial resolution. And right now, clearly, we're focused right in this area. Okay, two objects, I like to say top to bottom, but it's parallel to the ultrasound beam. Lateral resolution are two objects, represents a minimum separation from other tissue the ultrasound beam can distinguish in a plane that's perpendicular to the ultrasound beam. So now these objects are, instead of top to bottom, they're left to right, if you will. And you can see we've illustrated the two objects in the middle where it's clearly focused, and the focus is narrow enough so that it can represent one object. So it'll see these two objects as two objects. But up here, because the focus is wider than the actual objects themselves, they would be seen as one structure. And the same thing in the far field. So lateral resolution is perpendicular to the beam path. And again, I call it left to right as a way to remember. Left to right, L lateral starts at left. So it helps me kind of remember the difference between axial and lateral. If you have an issue trying to remember that. But you can see here's an example of an image where the objects are blurring together and not being represented as independent objects right here. So that would be, again, a representation of poor lateral resolution. And just a side note here, the resolution array right here that's set up on what we recommend is the 539 Phantom, the model 539. This resolution array allows you to capture images that help you evaluate axial lateral resolution. So you have axial going top to bottom and lateral going left to right with a curve kind of representing both, or detail resolution. Transverse resolution, we don't spend a lot of time talking about, but I wanted to define it. We had axial, two objects going from top to bottom or vertically. Then you have lateral resolution, two objects side by side or horizontally. And transverse is now going from the front to the back of the phantom. And what I want you to understand about this is these two objects would be seen as one based on any kind of 2D image. In order to measure transverse resolution, you're really talking about a 3D, 4D probe. And it's not something that anybody's ever required by any kind of accreditation, such as American College of Radiology or the Intersocietal Accreditation to measure. So it is a way for you to kind of evaluate 3D, 4D imaging if you have a system that does that. But there's no accreditation requirement to report or measure on that. So we have a poll question. I just want to get some feedback on it. Which statement best describes the relationship between frequency and axial resolution? A, higher frequency equals lower axial resolution. Higher frequency, or B, I'm sorry, higher frequency equals higher axial resolution. C, frequency does not affect axial resolution. Or D, lower frequency equals higher axial resolution. Take a minute to answer this question, and Linda will let us know what our results are.
Okay, Jim, the results are in, and you've got 100% for higher frequency equals higher axial resolution.
That's exactly right. And specifically, axial resolution is frequency dependent. I mean, frequency has the highest impact of anything on axial resolution. So good job. That's awesome. Certainly shows that you understand the relationship of frequency. So awesome. Thank you. So moving on. Image uniformity. This is one that's, it's hard to define. I mean, it's really not hard to define, but when you talk about it, people kind of waffle back and forth what they're saying, well, how they try to define it. And kind of a simple way: comparable detail and contrast throughout the image. Image should look uniform from top to bottom and left to right. And I have an image here, and it's pretty uniform from top to bottom, left to right. Top to bottom, there aren't any dark shadows that go throughout the image. People say, well, there's a dark area here, but that's basically the fluid right here. It's represented because it's not a very dense object, so it's mapped to the dark spot of the grayscale. But it's just as bright at the bottom as it is at the top when you consider the different tissue types associated with it. Some other people notice that there's a shadow going through the image right here, and also down in this area you see a big shadow here with kind of a dropout, if you will. And the reasons we have these dropouts, if you want to call them, I prefer shadows, is because you have this very dense bone structure right here, the jaw, and this bone structure causes a huge loss of acoustic energy as it penetrates deeper into the body. So when you give all your echo back to the surface and you get very, very little acoustic energy traveling beyond, what you're going to end up with is a shadow beyond. And same thing here, you have the baby's fist balled up, a lot of bone structure, fairly dense structure, and it creates a shadow underneath. And that's what this shadow is. Why isn't that a dropout? If it was a dropout, it would be originating from the top of the image and going all the way through it. So some different ways of looking at image uniformity here that I like to point out. When you're looking at dropouts specifically, they will originate from the top, and they will be vertical in nature, going from top to bottom. Contrast resolution. Contrast resolution is one, even the ACR accreditation doesn't specifically say you have to measure contrast resolution, but I find that it's one of those things that's just very, very critical to measure. And in many cases, nobody ever checks it. When I check it on most ultrasounds, for example, this object, the -3 decibel, you can see they're all, they have designations, excuse me, +15, +6, +3, -3, -6, and -15 decibels. The -3 decibel one, for whatever reason in ultrasound, is the most difficult one to see. It blends in with the background structure, which is 0 decibels. All this empty area out here, it surrounds all these objects, is at 0 decibels. That's the average density of human tissue. So this object is the most difficult of all of them to see, and it's just something to pay attention to. But what you're looking for is these 6 large objects, that each object is a different density, which we know, but that it's represented by a different shade on your ultrasound system. So when you're viewing them, just to be able to see these 2 objects isn't enough. You have to be able to see them and see that they're different shades, if you will, different shades of gray. Okay, so you want to be able to see all these objects. It doesn't have to be in one image. You can be using a linear probe, and maybe you can only see 2 at a time. But between these 2, you need to see them both and see that they're different. Same thing with these 2, and so on as you move down. So as you evaluate it, you need to see all 6 and see that they're dense. This being the least dense object, which is represented by black, and the most dense object at the top, which is white, represents the most dense, or close to bone, if you will. All should be visible, and all should be different shades. So the question I get a lot is, do we need to check contrast resolution on every probe? And the answer is no. For axial and lateral resolution, we certainly need to check every probe to determine what their axial and lateral resolution capabilities are. And you want to use the resolution array, as we defined earlier, to get the best image possible and make a record of that. Take a picture of that. Have a printout if you have a printer, but make sure you capture what you can get. And you need to do this on every probe, because it is frequency dependent, as we talked earlier. Frequency, the higher the frequency, the better the resolution. Well, contrast resolution is not frequency dependent. You should be able to see all 6 objects, whether you're using a 1 megahertz probe or a 15 megahertz probe. So this is really system dependent, not frequency or probe dependent. So for contrast resolution, you only need to evaluate contrast resolution using 1 probe. So keep that in mind, but it is a test and should be part of your printouts that you conduct during any preventative maintenance you're performing. This is one of the ways that you can determine degradation over time. So, and we'll talk more about that in a couple minutes. Temporal resolution and frame rate. I mentioned frame rate is how quickly the image area itself is refreshed. And it's normally measured in hertz, right? Frequency. And it's normally around 30 hertz, but there are things that can affect that. the number of focal zones in this image particularly, you can see we only have this one focal point here, which tells the system we're focusing in this area of the image. Okay, you could add focal points if you wanted, and that would make it clearer in a wider focal area. In other words, more of the area, more of the image would be focused. But by adding more focal points, you'll decrease the frequency or the frame rate. So if frame rate was at 30 with one focal point, you added 2 more, it might drop down to say 10 hertz. Okay, so keep that in mind. The number of focal zones, the frequency affect your frame rate. And frame rate and temporal resolution are inversely proportional. So as your frame rate decreases, your temporal resolution will increase. So just a little bit about that. So we have time for another poll question. So you see 2 small cysts side by side, perpendicular to the ultrasound beam. They appear as one blurred structure. Which type of resolution is most likely the problem? We have A, axial resolution, B, lateral resolution, C, contrast resolution, or D, temporal resolution.
Hey, Jim, I'm closing the poll, and you have got 20% for the axial resolution, 60% for the lateral resolution, and 20% for the contrast resolution, and 0 for the temporal resolution.
Thank you. Well, let's talk about that a little bit more. Because the cysts that we're talking about are side by side or horizontal, perpendicular to the ultrasound beam, that specifically is lateral resolution. Again, axial resolution is vertical in nature, or one on top of the other, or parallel to the beam path. So I know it's very hard to remember the differences between axial and lateral. Axial, I just remember top to bottom, lateral left to right, and again, lateral starts with an L, as does left to right. So that's how I kind of remember them. Left to right is side by side. So I'm not sure if that helps, but lateral resolution is the correct answer. And again, if you ever have any issues on these tests or have questions, don't hesitate to reach out to me. I'd be happy to answer these. Thank you. Moving on. Phantom tests, and these are the tests that we want to talk about in kind of in depth, if you will, that we want to perform with a phantom. Some of them are dictated by, for example, American College of Radiology, and let's say the Intersocietal Accreditation for Cardiac Systems. Some of them aren't. I recommend doing these tests on every preventative maintenance. It's how you record them and report them will make the difference on whether you're ACR compliant, as an example. But having this information will only help you in the future if you have an image quality issue. And again, one of my least favorite things to troubleshoot is image quality issues. When you're talking about sonographers that are saying, well, the image is mushy or grainy. You know, the ones that are easy is the huge dropout right in the middle of the system. Well, those are easy for us to troubleshoot. But some of them are very subtle. Some of the artifacts are very subtle and very difficult to see. So let's talk about it a little bit more. We're gonna talk about system sensitivity and penetration testing. Don't let the word sensitivity bother you. It is penetration testing. we're going to use the ability of the ultrasound system to display weak echoes from small objects. And I'll show you a picture. We'll describe how you use a phantom to do sensitivity / penetration testing. Again, people often get confused about the sensitivity. It is just penetration testing, okay? Axial, lateral resolution, we defined them. Again, what we're looking for is the minimum separation between two closely spaced objects. On the 539, the phantom that we use and I recommend, it's not because there aren't any good phantoms or other phantoms aren't good. I'm not suggesting that they're not good. They all image very well. There's some very good ones out there. The reason I like the ATS or the CIRS now, who bought out ATS Phantom, is because there's no PM required on them. There's no liquid inside them, no fluid that evaporates over time. You can leave it in your trunk. You can leave it when it's cold. You can leave it when it's hot. And all your limitation is make sure you bring it back to room temperature before you're doing some of these tests. That's the reason I prefer the ATS model or the CIRS model 539, is because some of the advantages it offers with no PMs, no annual inspection, no recharging type things. So contrast resolution, again, sorry, the ability to differentiate different tissue types, which is different tissue densities without introducing noise. Geometric accuracy, vertical and lateral. You want to use your calipers to measure objects on your phantom so that you can ensure that the accuracy of your caliper measurements are within tolerance. There are tolerance if you're accredited, but if you're not accredited, it still gives you an indication of how your ultrasound system calipers are measuring. So we'll go over these tests and kind of define them over the next couple minutes. So, okay, system sensitivity or penetration testing, the ability to display weak echoes from small objects. It's extremely important to correctly interpret and diagnose. Oftentimes, many people use the wrong objects on the phantom, and I'm going to point those out on the next slide. We'll go back and forth so you get a good understanding. Max depth is affected by output power, time gain compensation, which is your TGC sliders on the control panel, gain, frequency, and focus. Make sure you're setting these consistently throughout the PM. So if you come do a PM in January and you go back in July, you want to make sure you're using the same output power. The TGCs are relatively the same. Your gain is the same. Your frequency, you're using the same frequency. And you're looking at things the same way, basically. So you don't want to compare apples to oranges. You want to be apples to apples, right? And that's really the important thing, is be very pointed and very objective about how you're setting the system up, being very consistent. Record findings on hard copy. It's not necessary to do hard copy unless you're accredited. If you are accredited, they do say that you should have hard copy printouts of your findings, of your pictures. So make sure that if you are at an accredited facility, that you take the time to print them out. If they don't have a printer on the system, send them to a PACS reading station, have them print them for you and leave them with the system. So I put on there hard copy, but for just a PM, we just attach pictures to our PM report. So we have them for our PM if there's no accreditation involved. Findings should remain consistent over time. What you're looking for is degradation over time. That's what the preventative maintenance is all about for as far as image quality portion of it goes. We're going in there and we're evaluating the system to see if anything's changed over time. So it's important for us to have pictures from the last PM and compare them to pictures of this PM and see if it's consistent, see if our penetration testing is resulting similar results. If we were penetrating to 10 centimeters in January and we can only get to 6 centimeters in July, well, there's clearly something has changed over time, and now you have you have to go in and do some investigation and find out what has changed over time and correct the issue. Axial, lateral resolution, we've talked a lot about the definition of them. Again, there's an axial lateral resolution array. There is no measurement that you can take that says, oh yes, I'm meeting a requirement or I'm failing a requirement. What you're doing is you're taking each and every probe and maximizing getting the best image quality you can of this resolution array. And once you have the very best image quality, you make a hard copy printout or even a electronic copy, save it and send it to PACS so you can recall it in the future and compare it. So when your sonographer 3 months later says my image quality sucks, you can say, well, let me take a look at it. And you can compare your axial lateral resolution today to an image you took 3 months ago that you knew was working because they were happy with the image back then. So important part, there's no pass fail limits to this. It's set the system up to get the best image you possibly can and take a picture of that. Again, poor resolution means objects start blurring together. That can be normal for the probe you're using. Let's say you're using a extremely low frequency probe. Maybe that's the best it's ever going to get, but at least you have a printout showing what the best image you could get at that time was. Again, hard copy printouts, and you're looking for degradation over time, which you'll hear me say on all these tests. That's an important factor while looking at phantom resolution. Contrast resolution, different tissue types. Again, that means different densities. Using the amplitude of the received echoes mapped to a grayscale. So what we're talking about is, this is clearly muscle tissue, probably the abdominal wall right here, and you map the density of this structure to the grayscale right here. So it falls in this area somewhere, and that's an indication of the density of this object. This is not very dense right in this area. It's mapped to the darker part of the grayscale because it's not very dense. And you have the baby's forehead here, a bone structure, very dense, very, huge echo, and it's mapped towards the white portion of the grayscale. Again, you want to make sure that you evaluate the 6 objects on your phantom and use that to watch for degradation over time. Okay, geometric accuracy, just before we get to this, when we talk objects, small objects for penetration testing, you can see these rows. There's 3 of these objects at the very top, and then it goes to 5, which include 2 larger ones, and then 3, 5, and so on as it goes down through the phantom to the bottom. These are the small objects you want to use to evaluate penetration testing. Okay, I want to make sure we understand that. In the past, I've seen people use these objects, which clearly are small objects, but these are highly echogenic objects, these ones here. they'll give you an echo till the end of the earth. I mean, they're basically metal nails going through the phantom, if you will. So you'll get an echo from way down here on this particular object. But when you try to find these objects, you may lose it right in this area, even though you can see this object way down here. So don't use the wrong set of objects. When you're talking penetration testing, we're talking these dark black-like cysts that are going to be represented on your phantom, and we want to use these smallest ones to evaluate how deep you can visualize this object and report on it. Okay, again, axial lateral resolution, we use these objects, and then contrast resolution, we use the 6 objects. So I just want to show you the different objects we're using in the phantom: penetration testing, axial lateral resolution, contrast resolution. And then for geometric accuracy, we have a series of objects. When you actually have the phantom, on your phantom, you'll see these objects right here from one to another are defined as 1 centimeter apart from each other. So this is 1 centimeter. On your phantom, these 2 objects, this one to this one, are identified as 2 centimeters apart from each other. So when I do horizontal and vertical caliper measurements to confirm geometric accuracies, I actually do 2 centimeters vertical. So I go from this one to this one, which is 2 centimeters. And in horizontal, I go from here to here because it's defined on the phantom that way. That way, there's no doubt that I'm getting an actual definition, a defined measurement based on what's on the phantom. Okay, it's not marked in this slide, but if you have the model 539, it is clearly marked as each one of these being 1 centimeter and this being 2. So one of the things to keep in mind also is temperature of the phantom. I mentioned you can carry the model 539, the one we use, in the trunk of your car. I lived in Phoenix, you know, it could be 125 outside. You could be more than that in my trunk. I get it out of my trunk, I bring it in to do a PM, and I just get it to room temperature. You can put it in tap water, just get it to room temperature, because the temperature of the phantom will drastically change the measurements that you're getting. So please don't make the mistake of a super cold phantom or a drastically hot phantom, using it to confirm caliper measurements, because they will be off. Okay, vertical distance errors are far less likely than horizontal. So you'll get much more accurate going vertically than you will horizontally, and that's a limitation. That's ultrasound physics. I'm not going to get into the physics of that, which is fine. Just understand you have a bigger tolerance horizontally than you do vertically, and that's important. Okay, another couple poll questions. Which of the following factors can significantly affect geometric accuracy measurements when using a tissue mimicking phantom? The temperature of the phantom, question A, or answer A, excuse me. B, color of the ultrasound display. C, brand of the ultrasound gel. Or D, room lighting.
Okay, Jim, I'm going to close the poll. Okay, you have 100% temperature of the phantom.
Yeah, I kind of just finished talking about that, so it's not surprising. But it is when you travel, if you're traveling, for example, field service engineer, how often your measurements can be off a little bit because you didn't take the time to let your phantom come to room temperature. So just pay attention to that. And one more poll question. How often does your practice currently perform quality assurance testing on your ultrasound systems? A, daily or weekly, B, monthly, C, quarterly or yearly, D, never or you're not sure.
Okay, here we go. Right, Jim, you've got 17% daily or weekly, 17% monthly, 58% quarterly or yearly, and 8% never.
Yeah, that's believe it or not, that's pretty common. Daily or weekly, I like, but really that becomes an operator function. You know, some people who are using the systems daily. It's not really FSE or clinical engineers, biomeds, imaging engineers. We tend to do it more quarterly or yearly, semi-annually. But in either case, it is important that you have a quality assurance program. So if you don't have one, it's something you should certainly set up and evaluate, because a lot of potential problems can occur, and we want to limit our liability and increase, you know, our ability to correctly diagnose patients. So it is a pretty critical area. So thanks everyone. So let's move on to the final aspect of this. We got to ask you some questions. So now for the next few minutes, please take the time to ask any questions you may have, and I'll see if I can answer them. If for whatever reason I'm unable to answer them, I will get a copy of the question, and I will make sure that I reach out to you with a complete answer.
Perfect. Thanks so much, Jim. We've got a couple of questions here. Now, in your experience, what is the most common image quality issue you see veterinarians or sonographers overlooking until they actually use a phantom?
That's a tough one. It's a good question. The unfortunate part is many practices, veterinary end users don't use phantoms, so they rely on you know how they feel about an image, which is a problem to some extent. I wish imaging centers and veterinarians would invest in the phantom so they can do their own evaluations after being trained, you know, briefly trained on phantoms. But really, I think they get to see dropouts. They get to see the lack of detail resolution or even contrast resolution. I think those are things that the phantom highlights, especially over time. As you use an ultrasound system over time, you tend to forget, or you tend to get used to how the image looks over time. And, you know, if you could go back and look at it 6 months ago, you go, wow, that image is a lot better 6 months ago. But you just got used to it over time. So I hope that answers it.
Perfect. So how often would you recommend a practice test its ultrasound systems with a phantom, like monthly, quarterly, or only when they suspect an issue?
Well, the reality is you should, you know, probably test it, I would say quarterly to semi-annually. All of our customers, we highly recommend semi-annual PMs that include image quality. The other times that I recommend checking image quality is if you get a new probe. Let's say maybe the probe got damaged, got dropped accidentally, and you got a new probe put in-house. Well, when it gets put into service, you should immediately do an image quality test using a phantom on it and establish a baseline for that probe as it enters service at that facility. So I would say the answer is semi-annually, or anytime a significant change to your system or probe has occurred a major repair. For example, a board has been replaced or a probe's been replaced.
Perfect. We've got time for one more question, Jim, and that is, for those watching who have never used a phantom before, what is the single biggest aha moment you expect them to have after running their first sensitivity or resolution test?
I think one of the things that I find amazing is how much frequency matters. And you have a probe, for example, that maybe go from, let's say, 2 to 5 megahertz, and you put it on a system, and you're looking at an image quality, and most beginners use a single frequency. It's whatever it defaults to, and they don't realize that there are 2 other frequencies that they can dial in. And by being able to change the frequency and change the focal point, they can drastically affect how the image looks. And I think once they realize just how much influence they can have over the image when they have a phantom to look at and learn to manipulate the settings, I think it's a real eye-opener for them.
Perfect. So thank you so much, Jim, for your time today and for a great presentation as usual. Now, if you would like more information about today's sponsor, please visit advancedultrasound.com. As promised, the answer to today's trivia question is lime juice. So congratulations to our winner, Virginia Howard. Just a quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's live webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. So please visit icewebinars.live for more details of upcoming ICE webinars and, of course, complimentary registration. Now, if you've missed any of our past ICE webinars, again, please visit icewebinars.live to view our whole webinar archive. So thank you all for your time today, and I hope you enjoy the rest of the day.